welcome to the program. I'm your host, Neil Howard, here on Health Professional Radio. Real glad that you could join us for another segment. We're going to be speaking with Dr. Robert Keenan. He's joining us here from the Duke University School of Medicine to talk about gout, how, if left untreated, can lead to some very serious health conditions. Welcome to Health Professional Radio, Dr. Robert Keenan. Thank you so much for taking the time.
Well, thank you for having me. One of my favorite topics to talk about.
Well, give us a bit of your professional background and tell us why this is one of your favorite topics.
So I'm a rheumatologist. I've been in practice and doing rheumatology, so to speak, for about 15 years almost now. And I was at Duke for the last almost 12 years until recently going into private practice with a large group in the Southeast. And I got involved in gout and gout research actually when I was a resident, and I further cultivated that interest in fellowship and developed a database there and did some studies and just kept it going. When I got to Duke, I started a gout clinic, and there was a lot of naysayers at the time and didn't think I'd be busy, but I was extremely busy, and I went from having it once a month to once a week. Because there's definitely a need out there, and it's definitely seems like an underserved and underappreciated disease state, which is another reason why I have a significant interest in it. In addition to the sheer fact that it's one of those things we can actually fix 99.99% of the time, and a lot of people, including providers, don't realize that.
So what is gout and what causes it?
So gout is due to, first you have to have hyperuricemia, or too much uric acid in the blood. And when there's too much uric acid in the blood, you kind of got to look at it like pouring sugar into cold tea. If you got too much, it's going to all kind of sink to the bottom and deposit. With gout and uric acid, we all make uric acid. We all make, various amounts depending on, our metabolism and what we eat and what's in our diet and all that good stuff. But what's even more important for developing too much uric acid in the blood and subsequently gout is how your kidneys and your gut, more so the kidneys, handle that uric acid, how much they hold on to versus how much, the kidneys get rid of it. And most patients with gout have gout due to too much uric acid, not because they eat too much bad foods or gouty foods or foods with what they call high purine content, but because of their kidneys and to a certain degree their gut holds on to that uric acid. And that's usually due to a number of things. It could be due to anything from using diuretics or having just decreased renal function as we get older, or any other kind of problem with our kidneys in general that decreases how much they're able to filter, so to speak. So because of that, when the uric acid gets too high, the blood gets what they call supersaturated. So the concentration is too high. So when the concentration is too high, the uric acid, which is soluble in the blood, kind of starts to basically form crystals. And those crystals end up depositing in the joints and the soft tissues.
How's this condition treated traditionally?
Well, traditionally, people think about gout and they think, oh, you're having a gout attack in your big toe, for example. That's kind of what the classic perception of gout is. Those crystals stir up the immune system and cause a significant, severe reaction or flare up in most patients. So the immune system goes after them hard, and because of that, all the immune system, including neutrophils and lymphocytes and other parts of our immune system, kind of go after it and create the inflammation that leads to the swelling and the redness and the pain and the increased warmth that is associated with the big red hot toe that people think about gout at. Now, gout can go in other places, of course, besides the big toe, and a lot of times it does, and a lot of times that actually kind of throws patients and providers off a little bit as far as what the potential diagnosis could be when it doesn't just occur in the big toe. So to treat that, most people just treat when that acute flare occurs, and so they'll give them either colchicine, for example, or they'll give them nonsteroidals like indomethacin is the classic nonsteroidal that's used. And then, of course, they'll potentially give them prednisone as well to take to try to calm down the inflammation right then and there. A lot of times, unfortunately, people don't realize that, in between those flares, even after you treat and the flare goes away, that there's still those crystals sitting in the joint, and also that those crystals are still kind of inciting the immune system to kind of have this low level of inflammation. And when those crystals are sitting there and the uric acid is still high, is still elevated, those crystals continue to deposit. So, that leads to what they call, a tophus, which is a collection of crystals and other inflammatory cells and fibrous material. And that, accumulates over time when the elevated uric acid is not appropriately treated or addressed.
Are these treatments always effective? Are they effective in some patients, or sometimes they're not effective at all?
Yeah, so all above, basically. So when you're treating an acute flare, acute gout attack, usually people think, okay, let me give you colchicine and see if that calms it down, or let me give you some nonsteroidals and see if that calms it down, or give me some prednisone and see if that calms it down. And a lot of times, one might not work for one patient, but works for another. Some patients need all three, for example. Some patients might need two of those things to get it to calm down. Mm-hmm. And most patients, not all, but most patients, even if you did nothing for the gout flare, didn't do anything, even including icing it, for example, the gout flare will usually resolve on its own after about a couple of weeks, 10 to 14 days. It's not always the case, of course, but a lot of times that's the case, especially when the patient's gout is not mm-hmm. too severe. Now, there's other things that, of course, can treat a gout attack, and that's including injecting the joint with steroids, for example, and all that. All those things usually are relatively effective, but the problem is too, once you treat it, it can still come back, and it can come back a week later, can come back a year later, can come back six months later. And so, or it can deposit, and the crystals are depositing, and if they're depositing in one joint, they're usually depositing in another, or in the soft tissue, or along the tendon sheaths. And so usually, if you have one area of gout, there's usually another one somewhere around that just hadn't reared its head yet.
If left untreated, it could lead to some other serious health conditions. But we just talked about some of the treatment options. What if those options don't control the gout?
When you're treating the kind of the root cause of gout, the hyperuricemia, that is, you want to lower the uric acid. So the treatment options for lowering the uric acid are different, of course, than treating the acute flare, and that includes things like allopurinol, which has been around since the 60s when it was first approved for gout. And then also another similar acting medication, but a little bit more specific, is febuxostat. And those both lower the uric acid. And there's a few others out there that, including probenecid in the United States, that helps you pee out or urinate out the uric acid. And then there's what they call a pegylated uricase, which is an IV medication that puts back that enzyme that we don't have as humans, and that, third world monkeys and apes, and for whatever reason, Dalmatians do not have. And that's the enzyme that breaks down the uric acid to something called allantoin that we easily excrete and easily get rid of. And, so there's kind of a stepwise approach usually to patients with gout, and depending on their severity, if you have a patient that has just, maybe one flare every now and then, and every, once or twice a year, you might put that patient on allopurinol and be fine. There's those patients who continue to have flares despite the allopurinol or despite the febuxostat, continue to have flares, continue to have crystal deposition, and those patients are, they're considered the more severe or refractory patients, and those patients, they're usually best served with treating with pegloticase, the IV therapy.
What about some of the long-term complications and comorbidities associated with uncontrolled gout?
So that's a good question. People don't understand here again. I was talking about the low-grade inflammation that occurs while gout's going on, even between the flares, and that subsequently could contribute to a lot of things that, like cardiovascular disease, for example, or chronic kidney disease, for another example. Obesity and insulin resistance are all could be attributed to, or at least comorbid associations, or that go along with gout. People in the medical community kind of argue back and forth a little bit, because there's not definitive studies saying that, okay, gout causes X, Y, and Z, but all of the epidemiological research looking at large databases and retrospectively shows an independent risk factor for things like even hypertension, again, cardiovascular disease, increased risk for heart attack, and as well as chronic kidney disease, insulin resistance, and metabolic syndrome, and obesity, and all those kind of things can go along with gout and hyperuricemia.
Dr. Keenan, I appreciate you joining us here briefly on Health Professional Radio and giving us that information and that information resource as well. Thank you so much for joining us here on the program.
Thank you for having me. You have a good evening.
You do the same. You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Robert Keenan, Adjunct Clinical Professor at Duke University School of Medicine. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download it at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.